Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today we're going to discuss this acute viral hepatitis. As you can figure out from the name, it is an acute infection of the liver due to virus, and there are a number of viruses which can cause this, and clinical syndrome is almost similar. So in this lecture, I'm going to cover acute viral hepatitis in general. I have other videos specifically addressing hepatitis B and C. So if you're interested in those conditions, you can refer to those videos. But here, just an acute illness which is caused by any of the 5 viruses will be discussed. And very unfortunately, this condition is still common in our country because of our poor personal hygiene and general hygienic condition in the country. So this is fairly common. What is the definition? It is acute inflammation of the entire liver. Now, of course, this should be understood, but I want to emphasize that in viral hepatitis, it is the entire liver which is inflamed, and this is due to one of the 5 known viruses. And what are those 5 known viruses? I'll just give you the list. But sometime all those 5 viruses, when we do the test, and sometime it may not be one of those 5 viruses, and I believe some other viruses still unknown can also cause viral hepatitis. And all those conditions which are generalized viral infections like measles, mumps, rubella, in all these conditions, liver is also inflamed, but that does not cause typical syndrome of acute viral hepatitis. When we say acute viral hepatitis, we usually mean a condition which is primarily focused on the liver. Of course, in that also there is generalized inflammation, there is generalized viremia, there are other systems which are affected, and sometimes there may be significant symptoms coming from other systems, but primarily it is viral hepatitis because this virus has got some affinity for the liver. The clinical syndrome is indistinguishable between them. Of course, based on patient's age and the previous history and overall condition, we can make a reasonably accurate guess also if it is hepatitis A or E or C or E. But theoretically, you actually cannot make a precise diagnosis unless you go for the test, and clinical syndrome is the same, which I'm going to describe. That is why I'm covering all these conditions in one lecture. So this is the list of viruses. These are very well known: hepatitis A virus, hepatitis B virus, hepatitis C virus, hepatitis D virus, and hepatitis E virus. Now I have listed, coded them in colors. C and D are coded in blue. That means they can cause chronic liver disease also. And B can also cause chronic liver disease. This A and E usually cause acute disease and usually do not cause chronic disease. Hepatitis B is DNA virus and all others are RNA virus. Hepatitis G virus is also one of the conditions, one of the viruses which can cause hepatitis, but we still are not sure if this is responsible for hepatitis in humans, and other viruses are also possible. As I explained, in all patients with acute viral hepatitis, we do not identify one of these 5 known viruses. This hepatitis D virus is not a complete virus, and it usually will cause acute hepatitis only if somebody is already infected with hepatitis B virus. Somebody has this hepatitis B surface antigen circulating in the body already, and only then hepatitis D can cause infection. Hepatitis C usually, this hepatitis C virus usually cause chronic disease, but cases are on record when it can cause acute hepatitis also, particularly if exposure is documented. You know, somebody has been exposed to hepatitis C virus, and then we follow it up, and then we can identify acute viral hepatitis with hepatitis C virus also. But three most common viruses when you see a patient, if you have a patient with acute viral hepatitis, the three commonest which are coded in red, A or B or E. These are the commonest viruses which can cause acute hepatitis. A is usually seen in children and E is usually seen in adults, particularly in our part of the world. Now, hepatitis E is particularly common in our part of the world, in Indo-Pak area of the world. So this is the brief summary. Etiology. It is not actually essential to identify a particular virus in acute viral hepatitis for the management of acute illness, but we do the test. Why? Because we need to know which virus is responsible so that we can determine the prognosis, and we can also determine how long this patient needs to be followed up, and as will be obvious in some subsequent slides. Clinical presentation. First of all, there is incubation period, and that means patient does not have any symptoms at all. Patient has been exposed to the virus, and that exposure may be documented or may not be documented, mostly not documented, but patient passes through this phase. There is no symptoms at all, no specific liver symptoms, no systemic symptoms at all. So patient has got viremia. If you do viral test, if the exposure is known and if you want to do the viral test, the virus may be present in the body, proliferating, circulating, but there will be no symptom. If at all, there may be very mild non-specific symptoms like fatigue, but no different symptom. Then there is prodrome, and this is actually when there is significant viremia. Then patient starts having this non-specific symptom. This may be feverish feeling, or this may be fatigue, this may be body pain, this may be headache, this may be loss of appetite, just flu-like symptom, like somebody says he is not exactly himself or herself. But patient is usually unable to identify any specific symptom. A shrewd physician may be able to suspect here also hepatitis, but mostly this is a non-specific illness, and patient usually does not seek advice of doctor, and even if the patient goes to a doctor, that patient is usually treated non-specifically with paracetamol or non-specific medication. This is the phase where we can identify. Ecteric phase means patient has got jaundice. Jaundice, of course, is the cardinal symptom, and there is progressive jaundice, and then there is also dark urine. In fact, dark urine may usually precede this appearance of jaundice. Now, if you suspect jaundice, patient based on anorexia, nausea, vomiting, fever, and general poor health, and if you suspect jaundice, and you of course will physically examine the patient and you may be able to detect jaundice, but many times if you ask the patient what is the color of the urine, patient would say it is dark color like Coca-Cola, or orange color or mustard color. So if patient says or just simply says very dark, then of course that may suggest hepatitis. Initially, jaundice may be undetectable. Now, I've just covered one video on approach to jaundice, but initially jaundice, we will say jaundice only when there is clinical jaundice. When bilirubin rises up to 3 milligram, only then jaundice becomes visible. So it will be progressive jaundice. That means initially doubtful jaundice, when it becomes more obvious, and it will, depending upon individual patient, it may be very dark or it may be moderate, but bilirubin may go up to like 20, and then it becomes static, and it remains static for several weeks, and then it comes down. So this is progressive jaundice. I think this is the phase where most patients are diagnosed. Then patient starts recovering. The specific symptoms go away, but patient continue to feel lethargic, appetite returns slowly, and the strength also returns slowly, and over a variable period of time depending upon which virus is responsible, I think 4 to 8 or 12 weeks there is complete recovery. So this is the typical acute viral hepatitis. There are two exemptions. One is some unfortunate patient may develop what is called a fulminant hepatic failure. That is severe form of liver failure, liver hepatitis that can occur in any hepatitis, A or B or D or whatever. And the second exception is that patients sometimes may not recover, particularly in hepatitis B and C, and it may continue till 6 months or even beyond. So then it will be called chronic hepatitis. Lab investigation, the first investigation is LFT. In LFT, we usually do bilirubin, usually total bilirubin, and we also do ALT, AST, gamma GT. So liver enzymes are typically in thousands, and bilirubin to start with, of course, 1, 2, 3, and it keep on increasing. I think most patients would have bilirubin when the disease is fully developed in between 10 and 20. And this is mixed hyperbilirubinemia because the uptake of bilirubin and conjugation both are affected. So there would be mixed hyperbilirubinemia and it would be then repeated. I think I'm not very keen to repeat this test very frequently. In fact, I mostly discourage the patient to repeat the test very frequently because you don't get any additional information. Only when you suspect some complication, or sometimes after several weeks, I think just to be sure that recovery has started, you will do the test again. But you don't actually need to repeat them very frequently because you should know it is going to take about 12 weeks. Yes, you heard it right. You take about 8 to 12 weeks before ALT becomes normal. Usually ALT is the last to become normal. I think that needs to be done just to document that there has been complete recovery from acute viral hepatitis. Then PT-INR. This is actually the test for prothrombin. This is prothrombin time and international normalized ratio. So this may be done only in some cases when patient is very sick, then you do PT-INR. If PT-INR is affected, that means patient has got very severe disease. That would also mean that patient is at the risk of bleeding. But most patients do not have any prolongation of PT-INR. Why? Because though liver is inflamed, liver is not functioning, liver may not be producing more prothrombin, but prothrombin being a protein, the prothrombin which was secreted before hepatitis may be enough for several days. So maybe up to weeks. And so by the time the prothrombin is consumed, liver has already started recovering and usually there is no coagulopathy. But if patient is very sick and you suspect patient has developed fulminant hepatic failure, then I think you need to do PT-INR also. Then blood glucose is important because one of the functions of liver is to produce glucose, and patient may develop hypoglycemia, particularly because patient is very anorexic. On one hand, patient is not taking food, and on the other hand, liver is also not producing glucose, so there is a risk of hypoglycemia. You like to do glucose test, and those patients who have diabetes, in them there is also risk of hyperglycemia because liver plays a buffer role in glucose homeostasis. So there is possibility of both hyperglycemia as well as hypoglycemia. So glucose should be tested, and routine labs, of course, CBC and maybe creatinine, urea, and I think depending upon patient condition and availability of the test, other routine tests may also be done. Now, should we try to determine which particular virus is responsible for acute viral hepatitis? I think yes. Although the management of acute phase does not depend on the particular virus, But some viruses are known to cause a short illness, and other viruses may cause prolonged illness. And plus some other measures like vaccination and protection of the family also is based on which virus is responsible. So I think we like to do some serology. There is a very long list of serological tests which may be done in some cases, but I'm going to give you the most relevant ones. In hepatitis A, you go for IgM-HAV. We do not determine hepatitis A antigen, we go for antibodies. Now, it has to be IgM antibodies because we are dealing with acute viral hepatitis. In acute phase, you only have IgM. And most patients would have IgM antibodies by the time they develop jaundice. So because there was an incubation period before the jaundice appeared, so virus was already there and that had prompted the antibody formation, and by the time patient develops clinical syndrome of jaundice and antibodies are already present. So you can screen out hepatitis A by IgM-HAV. IgM referring to IgM class of antibodies and HAV is hepatitis A virus. For hepatitis B, you can do hepatitis B surface antigen. That is our usual first line screening test. If it is negative, you can rule out hepatitis B. But if it is positive, of course, most likely it is acute viral hepatitis B. But there is another possibility because hepatitis B may be chronic also. It is possible that that person was a chronic carrier of hepatitis B surface antigen, and this particular hepatitis may be due to some other virus. So we will also like to do IgM-HBC. This is antibody of IgM class against hepatitis B core antigen. These days core antigen itself can also be measured, but traditionally antibodies are measured because antigen mostly stays in the liver. So hepatitis B surface antigen, if that is negative, you can rule out hepatitis B, and if it is positive, further confirmation, I think you need to do IgM-HBC also. Hepatitis C, generally speaking, does not cause acute hepatitis, but if somebody has been recently exposed to hepatitis C virus and you monitor the patient, you may be able to detect hepatitis C in the acute phase also. So you would do anti-HCV. The typical screening test for hepatitis C is anti-HCV. That appears within weeks, maybe max 2 weeks. And again, patient may be chronic carrier of hepatitis C antibodies, and may be symptomatic, maybe asymptomatic, maybe previously treated, may not be treated. So if somebody has suffered from hepatitis C, antibodies will be present. So just want to make sure that this particular hepatitis jaundice is due to hepatitis C, you need to do PCR. So PCR should be positive. PCR means hepatitis C virus PCR, RNA PCR, polymerase chain reaction. Hepatitis D would become relevant only if hepatitis B surface antigen is positive. If this is negative, then hepatitis D test is unnecessary. But if you want to do it, would be anti-HDV, hepatitis D virus antibodies. So that can be determined. And for hepatitis E, again IgM-HEV. I think mostly, though, if we consider all these tests, they will turn out to be like 15,000 rupees. It's a fairly expensive test, but they give very useful information. I think you should do all these tests in acute viral hepatitis. Now, whether we need to repeat this test on when, I think for hepatitis A and hepatitis E, we know that these two viruses do not cause chronic disease. We have seen some rare cases of chronic hepatitis E, but hepatitis E almost never causes chronic disease. So after patient has completely recovered from acute illness, we know that there is no virus, so we may not repeat these tests. But for hepatitis B, C, and D, we definitely need to follow them up and need to be sure that this virus has disappeared. Hepatitis B surface antigen should be repeated after 3 months and then after 6 months. If the surface antigen is still present after 6 months, I think then patient has chronic hepatitis B, then DNA should be done and some other tests may be done. Then patient should be treated as chronic hepatitis B. I have a separate video on chronic hepatitis B. So this is the traditional classification. Now we have a factor treatment. I would be worried if somebody has surface antigen positive after 3 months also. So I think maybe I would like to do his DNA here also. Hepatitis C, again, we have very effective treatment available. So I think most patients should be negative by 3 months. So after 3 months, you will do the test HCV RNA after 3 months, and then after 6 months. After 6 months, definitely you need to treat them as chronic hepatitis. Maybe at 3 months, it is relative. Some physician would like to assume that the chronicity has already occurred and like to treat them as chronic hepatitis. Other would wait still wait for 6 months. But everybody would agree that after 6 months, if hepatitis B surface antigen is present here or this PCR is positive here, then they need to be treated as chronic hepatitis. Hepatitis D, same as hepatitis B. So this is the follow-up serology. Now let me explain how this condition developed, and this will help you to understand what physical symptom, what sign, which laboratory test to be expected at what time. Now initial symptoms are anorexia, nausea, vomiting, fever, jaundice, and dark urine. So these are the symptoms. They would be seen in all patients of hepatitis. Of course, the severity would vary, but everybody would have these symptoms. Now, ALT is the first lab abnormality. By the time patient feels anorexic, ALT is already high. So you can do ALT in the initial phase, and during your treatment, ALT will rise. I always explain to the patient, if patient comes to me after only 3 or 4 days after developing jaundice, I tell him that no matter what treatment you take, this ALT is going to rise further. This is just to educate the patient, because otherwise on the subsequent test, if ALT is further high, patient would think that the disease has now gone into a more serious phase, or the treatment has actually made that condition worse. So this you need to explain. ALT is high and is going to rise further. In I think 4 weeks, 2 to 3 weeks, it becomes static, remains static, and then it starts getting down. ALT is the last test which becomes normal. Earliest you can expect it to become normal is 6 weeks. And I think it may take 12 weeks. And it is followed by bilirubin. So bilirubin is after ALT. So there may be a phase when you do the test, ALT may be elevated and bilirubin may be within normal limits. That is definitely possible. But if the bilirubin is normal, patient would not have jaundice, but patient may have all other symptoms. Patient may have dark urine also. So this bilirubin also rises, goes up, and then becomes static and comes down. It typically follows the same pattern as ALT, but I think few days lag. Then viremia is present, although we normally do not do specific virological studies in this stage, the PCRs. But if you do for epidemiological purposes or in some specific patient, then virus will be detectable, and in fact it would be detectable even before the symptoms started during the incubation period. So viremia would be present. Then if it is a case of hepatitis A, now next 2-3 slides will explain, this is common to all, but if this is a case of hepatitis A, then you will have antibodies of M class against hepatitis A virus. It will be present during acute icteric phase and will remain positive at least for 6 months, maybe for maybe up to 1 year. IgM response is acute and stays for at least 6 months, maybe longer also. So this is the test, and if you do the test, you will know that this is acute viral hepatitis A. If it is hepatitis E, everything is the same, but you will have antibodies IgM HAV positive. Again, it will take about 6 months to start disappearing. Now is the hepatitis B. In hepatitis B, I think surface antigen is positive, and sometimes it becomes prolonged. Hepatitis B patient have the same symptoms as hepatitis A or B, but they are likely to be more sick. I think all these things will take more time to settle down, and viremia is also slightly prolonged. In the acute phase, you have surface antigen here. So for screening purposes, we use HBsAg, but in some cases, HBsAg may continue to be present up to 6 months, and that is when we label it as chronic hepatitis B. You may be surprised that hepatitis B, though we know it is a serious condition, if patient develops jaundice, that means if patient develop acute viral hepatitis in response to hepatitis B virus, then the chances of it becoming chronic is only maybe 1 to 2%. Most other will improve. Only if there was subclinical exposure of hepatitis B. Some patient after getting hepatitis B virus, they don't get jaundice. In them actually it is more likely to become chronic. Like if somebody, an infant acquired this virus from the mother, the chances of it becoming chronic is more than 90%. The difference is that it is the immune response in almost all viral hepatitis. It is the immune response which causes hepatocellular damage, which is responsible for the jaundice, but that is also responsible for viral clearance. Now, if this is subclinical exposure, then there will be no immune response, and it is likely to become chronic, more likely. Now, let me give you a summary of different viruses. I have already explained that acute illness is more or less same, but some differences are important to know. Hepatitis A virus is RNA. In fact, all are RNA viruses. Only hepatitis B is DNA. Now that may explain some different behavior of hepatitis B, because hepatitis B can affect nucleus of hepatocytes, whereas all these, they usually stay in the cytoplasm. So that may explain the different behavior of hepatitis B. Then the mode of transmission. Hepatitis A is fecal-oral. Hepatitis E is also fecal-oral. That means somebody acquired by contaminated food, and that food was contaminated by somebody who was excreting hepatitis A or E from his stool. So both could be prevented by good hygiene. Hepatitis B, hepatitis C, and hepatitis D, they are parenteral. That means they cannot be acquired by ingestion of contaminated food. They are acquired by parenteral route, like intramuscular injection, intravenous injection, blood transfusion, circumcision, tattooing, drug abuse, haircut, the contaminated instruments. So all these things, parenteral route, and from mother to baby, infant, all these routes are possible. Clinical, same type of clinical illness, except that hepatitis C is mild. If at all it causes acute hepatitis, it would be very mild, and hepatitis B and D patients are more likely to become more sick. Chronicity, hepatitis A never causes chronic disease, and hepatitis E also does not cause chronic disease. There are some exceptions, but I think generally you should still believe that hepatitis E does not cause chronic disease, and hepatitis B will cause chronic disease in 1 to 5%. and hepatitis C in majority, maybe up to 90% people who are infected with hepatitis C, they will become chronic. And in hepatitis D also, chronicity is possible. Fulminant hepatic failure. Now you may be surprised that all viruses, this A and E, generally have otherwise good prognosis. All can cause fulminant hepatic failure, but typically, luckily, certainly less than 1%. So I think we're lucky that they do not cause fulminant hepatic failure commonly. Hepatitis E can cause fulminant hepatic failure in up to 20% of the cases if it occurs during pregnancy. So I think that becomes serious. Now, vaccination for hepatitis A virus, vaccination is available. For hepatitis B, it is available. And for hepatitis E, it is also available. For hepatitis C, we do not have any vaccine. For hepatitis D, we do not have any vaccine. So I think these three, A, B, and E, are completely preventable by vaccination. Hepatitis B is actually universal these days, but others are optional. Those patients who have chronic liver disease, chronic hepatitis B or chronic hepatitis C, or I think some other chronic liver disease, it is recommended that they should have hepatitis A and E vaccination also, because they cannot take this insult of even acute hepatitis. Then a post-exposure prophylaxis. Now, what is that? If somebody has been exposed, you know that somebody was suffering from any of these viruses, another person has been exposed, and you want to prevent the occurrence of disease. Virus has already gone to that person, but you want to prevent the occurrence of the disease. That is possible. In hepatitis A, just immunoglobulin, just non-specific human immunoglobulin can be given, because normal immunoglobulin, they have activity against hepatitis A virus. Similarly here, but for hepatitis B, we have specific hepatitis B immunoglobulin. For C and D, we do not have any such immunoglobulin. Okay, so particularly in hepatitis C, we do not have any post-exposure prophylaxis. These patients may be monitored, and if they develop a sign of infection, they may be treated immediately with antiviral agent. Prognosis in hepatitis A, the prognosis is excellent. In hepatitis B, generally good, although patient has to go through a lot of problem, 6 to 8 weeks, but generally patient recovers. May become chronic. Hepatitis C may become hepatitis C actually becomes chronic very often. And prognosis in hepatitis D superimposed on B is very bad, and hepatitis E is good prognosis, except that it may become chronic in some cases. So vaccination, I think I would like to address. Generally, we recommend vaccination if a virus is likely to cause a chronic disease. But acute disease is also very, I think, disabling. Somebody may be very sick for 6 weeks. So if there is a vaccine which can prevent that acute disease, I think that is worth it. So you should need to consider all vaccinations in your patients. Treatment. Now, we go by symptoms, because we are assured that most patients will recover on their own. Some cases may develop fulminant hepatic failure, other may become chronic, but all others, most patients, they would recover. So there are no specific antiviral agents used in the acute phase. We just treat the symptoms. For fever, we can lower temperature by physical measures, by sponging, by air conditioning, by fan, or we can also use antipyretic. Now, you should be very careful choosing antipyretic, because all analgesic, all antipyretic may have problem in patient with liver disease. So I think if you have to use, I would still feel that paracetamol is still the safest. Although you know paracetamol is hepatotoxic, but paracetamol becomes hepatotoxic only in high doses. So I think you need to give it in a small dose. maybe 500 milligram 3 times a day. But it would be better if you just avoid antipyretic. You just reassure the patient that fever is not going to do any serious harm. So if patient can tolerate, or just control fever by simple physical measure. Nausea, vomiting is very common and very disturbing. I think domperidone, because domperidone is a safe drug. Ondansetron is also safe. These can be given intravenously or orally. And avoidance of solid food. Patient is usually anorexic. Patient has got usually food aversion, but still you should tell the patient not to take solid food, because if somebody takes liquid food, it may be easy to vomit out. But if patient has taken solid food, it is more likely to cause nausea and vomiting, and then the vomiting itself becomes a major issue. Fluids, patient is anorexic, patient may be vomiting, so you need to give fluids. After oxygen, fluids are most important thing. Ample oral fluids. Now in our culture, some specific juices, some specific drinks are recommended, but we as a scientist, we know that what we want to give to the patient is fluid, just water in any form. Of course, simple water may not be that palatable. You can give it in some different forms, any drinks, maybe fresh juice, maybe any drinks, whatever patient can take, I think they are all okay. If patient is unable to take orally, then of course intravenous fluids are recommended. In our culture, especially quack, they would tell the patient that this drip is going to make the recovery faster. We don't believe in that, but of course, if patient is not taking anything orally, IV fluids definitely are helpful. I think dextrose saline may be very good IV fluid. In diet, avoidance of fats and protein, because they pose, of course, some additional burden on liver. So liver is inflamed. To keep the burden low, we will avoid fats and proteins. Glucose or plain carbohydrate, as per patient's acceptance, may be given. IVs, if oral are not tolerated or inadequate, only then I think IV should be given. Dextrosaline, I think, is the most suitable IV fluid. Now, very briefly, fulminant hepatic failure. Definition: if liver failure occurs, and that will reflect in the form of encephalopathy or coagulopathy within 8 weeks of acute hepatitis. So that will be called fulminant hepatic failure, and it is very serious, and treatment is usually done in intensive care settings, because this patient is likely to have encephalopathy, and intravenous treatment is going to be needed, and this patient may develop bleeding, and some blood or blood products or plasma is going to be needed. I think this patient is best treated in intensive care setting, since it has got inherently poor prognosis. So we want to give him the best treatment, and that is possible only in the intensive care setting. Most patients should recover, but some would succumb to it. I think liver transplantation has come up as a very good treatment option. Liver transplant, of course, is not an easy thing, but in acute fulminant hepatic failure, liver transplant is perhaps the best treatment one can have, and after this successful surgery, patient can expect a normal life. Very briefly, chronic hepatitis. If viral serology remains positive after 6 months, then we call it chronic hepatitis. Hepatitis A and E do not cause chronic disease, and hepatitis B 1 to 5% progress to chronicity. Hepatitis C majority progress to chronicity, and hepatitis E variable number progress to chronicity. If they do develop chronic hepatitis, then they should be treated on the lines of chronic hepatitis. I have already told you that I've got separate videos on hepatitis C and hepatitis B. Please watch them also. Prevention, personal hygiene, hand cleaning. For hepatitis A and E, the patient should clean hand like one does before doing a surgery, like a surgeon does. So patient should scrub his hand with any soap available, and That patient should avoid handling food otherwise. Then avoidance of high risk behaviors, IV drug use and reuse of syringes should be avoided. Post-exposure prophylaxis is possible if somebody has been exposed before he or she develops illness. Immunoglobulin in hepatitis A and E or hepatitis B immunoglobulin in hepatitis B is possible. Then vaccination, universal vaccination for hepatitis B. I think these days it is done in the newborns, like universal vaccination. So all newborns should be vaccinated, but selected individuals should also receive HAV and HEV. I guess if cost is not a prohibitive factor, everybody should receive HAV and HEV vaccine also, but particularly those patients who already have chronic liver disease. Now this brings me to the last slide, which is summary slide. Acute viral hepatitis is a severe symptomatic disease with high morbidity and significant mortality. Morbidity is high. Patient is usually very sick. Patient is usually non-functional, away from work, and for maybe 2 to 4 weeks, followed by a period of weakness also. So this is a lot of morbidity, although luckily not much mortality, but there is mortality also, particularly in B and D. And most are preventable. Now this is interesting. Though they can cause acute severe disease, they can cause chronic disease, but they are preventable diseases by good hygiene and by vaccination. Most recover with conservative approach, I just mentioned, and only those who develop fulminant hepatic failure and chronic hepatitis need active management. This patient would require hospitalization in intensive care, maybe liver transplant. Chronic hepatitis, both B and C, are treated as outpatient. We have very effective antiviral agents for them. Thank you very much. I hope I was able to give you some good account of acute viral hepatitis. I again say this was about a general approach to acute viral hepatitis. Specific approach will be discussed in separate lectures. This is Professor Aziz-ur-Rehman from Medurstand. I look forward to see you in my next video. Thank you.